Again, I will not agree with you. You go to Bhagirath Palace in Delhi, behind Chandni Chowk, there is a huge market, drug market. You can buy meropenem in sacks. You take your shopping bag for vegetables, fill it up with meropenem, and put it into vials and sell it. So if you're using generic, please, all generics
Not about generic.
Are
Not
not
about
the
generic.
same.
But if you say a certain good Indian company which is selling in a good price, sir, it's not.
It
not
should
that
be
you
a
have to-
standard company. You should be aware of this good quality controls.
Yeah.
Not any company which is making it cheap.
Not about generic. Those who are standard listed company. but are you giving certificate? Those who are costly are good.
See, that's a question which is debatable.
not the
Many
question.
times,
Yeah.
some of the patients, my patients who come to the ICU, they have been on some antibiotic. Only thing I've done is I've changed from generic to the research molecule, nothing else. And the patient has got better. It is not the molecule. Molecule is the same, mind you. It's the bioavailability. They modify the release of the antibiotic. Of how much, because little bit of micromoles here and there will make a difference. So that cannot be a generic this thing that use a cheaper variety. That the administration will try to sell that to you. Yes. But it doesn't work like that.
Yes. Okay, thank you. May I invite Dr. Singhi sir for his talk before lunch? Since this is before lunch talk, I will request him to make it as short as possible.
I've changed it from the guidelines to current concept because guidelines means that there is a general consensus. And in fact, I'm going to talk about a few things which are not necessarily yet in practice. So I'll talk about CNS infections with saying that they are common in children as well as in adults and occupy a lot of space in emergency and ICU. Since I have been asked to go fast, I'll not spend much time on some of the things. So this is typically how they come, with altered sensorium, excessive crying for children or posturing, have tachycardia, tachypnea, and hypertonia, increased reflexes. We know that this is CNS infection, but which one? That is the first dilemma that we have. Often the fever or altered sensorium or fever and neurological signs. And how do we go about it is very important. Clinical syndromes of fever, seizure, headache, vomiting only tells us CNS infection. And meningeal signs do not mean meningitis all the time. That also we know. And especially in malnourished patients, children, and immunosuppressed patients, fever may be not so high grade as we are so often used to. So in such patient, diagnostic possibilities are several: acute meningitis, encephalitis, encephalomyelitis, cerebral malaria, typhoid, Shigella, herpes, brain abscess, and so many. So first thing that you need to know is when to make a diagnosis, and I just want to show that these meningeal signs or irritations are not very specific for bacterial meningitis. They only say that there may be raised intracranial pressure and there is meningeal irritation. So none of these things actually make a foolproof diagnosis. Even combinations do not help. But there are clues to viral infections that we often overlook. Rash, conjunctivitis, parotitis, pharyngitis, lymphadenopathy, pneumonia associated with CNS signs, enteritis, hepatitis. They point to some of the etiologies, and we should be actually aware of these. Enteroadenovirus, measles of course are easy to diagnose, so also is mumps, but CMV, varicella pneumonia, dengue associated with dengue causing encephalitis. These are difficult, and one should keep these in mind when we are talking about, when we are looking at a patient. So it's not only bacterial and any viral. There are viral that are now treatable, and that's why it's important. Especially varicella, CMV, dengue of course requires only non-specific but supportive treatment. They are all diagnosable and treatable, and so is malaria. So first thing I would like to do in any patient who is brought, besides thinking about a CNS, doing a LP and after fundus examination, rule out malaria if that is that's endemic in your area. And then take samples for these viral infections which are common. Although JE comes in epidemics, but that remains the most common cause of encephalitis. And worldwide, it is so. You can see that India almost is fully covered with JE, so it could occur anywhere, and this remains our commonest encephalitis. I think the data, if you just look at 3 billion people live in JE endemic area, and we have 30 to 50,000 clinical cases and 20,000 deaths because of JE in Asia only. And then there are, of course, many other organisms that cause encephalitis. But as I said, we need to be aware about what can be treated, and HSV, CMV, varicella, measles, they all need to be. And sometimes remember, measles may not have typical rash as we see in children often. And then tuberculosis, if there is a prolonged history. So these systemic manifestations help, but in most of the situations, it does not clinch your diagnosis, whether you need to give them antibiotics or not. And if a patient does not have any signs of raised intracranial pressure, only then one can perform a lumbar puncture. I'm sure all of you know the interpretation of lumbar puncture findings, but if there are cells and polymorphonuclear, one would like to treat them with antibiotics. If there are RBCs seen in the CSF, which was apparently non-traumatic, it is always a clue to herpes simplex encephalitis. And I would say that you would be proven more than 50% right if you follow that dictum and treat these patients for herpes. And a CSF glucose which is below 40 is always, for all practical purposes, would be taken as bacterial meningitis, though it could occur sometimes rarely in mumps meningitis or mumps encephalitis. I wouldn't give much importance to ADA for tuberculosis and all, but if CRP is very high, 40 generally, but even if it's above 20, and if you have no other etiological clue, one would think of bacterial meningitis. And we have used this definition even for inclusion of the patients with bacterial meningitis for research projects. And a gram stain, which we have probably forgotten as an art, that can give you immediate diagnosis within an hour of gram positive or gram negative organism, because there are only few, pneumococcus, gram negative based like Haemophilus and others, and antigen detection. Which is in our setup may be a cost-effective investigations because it can save a patient's life by giving you a specific diagnosis. The CSF picture I take generally as the few things that I would like to say. More than 1,000 cells is always bacterial meningitis. Anything less than 100, one has to think more like viral encephalitis. I'm not going to get into the debate of bacterial and tubercular and partially treated, and they are not easy to make out. But cells means meningitis, especially very high. And if you have few cells, it's more like an encephalitis, but there the proteins are also not elevated markedly. But these days what is available, and I think we are not using that often, is availability of these multiplex PCRs, which gives us a qualitative information in a very short period of time. And for almost all organisms that cause meningitis commonly and encephalitis commonly, we have multiplex PCRs available. And the importance of doing that is that many of these viral infections also can be specifically treated now. And so if you could have a way, this is again, as I said, as had been pointed out in the previous discussion, is a cost-effective one, because you know the diagnosis, you know the treatment, you would not over-treat, your patient would get well soon and go home, and you will also get some goodwill besides the good money. So performing PCRs on CSF, which has sensitivity as high as 100% and above 95% for most of the bacterial common ones, And then if you have access to imaging, especially for various meningitis, tuberculosis will show up on that, but for most of the viral ones, especially if a patient has focal signs or you are suspecting bleed, you should have an imaging. CT is useful only for suspected bleeds or for mass lesion. Most of the time you need an MRI. You don't need actually anything more than CT scan for seeing such lesions which are tuberculosis, but herpes you would always need an MRI, and it is in 2/3 of patient you would have a diagnosis on the day one. Nothing like MRI, which will show typical findings of hemorrhagic infarcts. JE encephalitis gives you again very typical picture, and we would like to make a diagnosis. You can see those hyperintensities in basal ganglia and thalami in midbrain in these patients. And a few more of those patients. And encephalomyelitis post-viral illness with all the demyelination of the gray matter, because that requires not antibiotics but treatment with corticosteroids. So an MRI can be very helpful. Enteroviruses showing typical findings, bilateral lesion in the dorsal brainstem, so symmetrical that you can see that there. And also rabies encephalitis. Our radiologist had been able to find these typical involvement, and also in the spine, also in the spinal cord, which is where there is myelitis in these patients. So involvement of basal ganglia, extensive involvement, is rabies. And then of course you have these cysticercosis and unusual CNS infections and toxoplasma showing these kind of lesions. And so MRI can be very helpful in making a diagnosis if you have one, access to it. Well, this patient had, of course, 40 cells, but all polys, and had shown gram-positive cocci. We treated him for pneumococcus. Later on, the latex agglutination also showed strep pneumonia, and this patient was on way to more specific treatment within hours. So what we follow is this algorithm, and this is also we have given with the tropical fever guideline, in which I would like to add a few things. You have a patient, stabilize him now, resuscitation, etc., if there is need be oxygen and all. But if there is focal sign or raised ICP, one would like to take, if there is raised ICP, then one would like to go straight for a imaging. And after imaging, if you still don't have a diagnosis, one would go for presumptive therapy. And here one should consider, besides what I've shown, all those tropical infections, dengue, scrub typhus, leptospira. And if there is lumbar puncture is giving you helpful guidelines, and the malarial parasite is giving you helpful guideline, that's really good. Why I'm saying that, besides bacterial and viral meningitis, you include this. This is the data from the first set of the tropical infection guideline. And if you look at this yellow line, of the 78 patients with encephalopathy, there are 15 meningitis and encephalitis, 15 only. But there is meningitis caused by scrub typhus in 10 of them. 14 had dengue encephalitis. And you have sepsis-induced encephalopathy in another 5, and with viral involvement of liver. And there were still 12 which were undiagnosed, and there could be a viral encephalitis. So we have to keep ourselves completely aware of a wide spectrum of disease that cause CNS infection. And you see even 2 patients with typhoid encephalopathy. So every time a patient comes with fever, seizure, unconsciousness, it's not only meningitis or encephalitis. We have these tropical infections which present with either encephalopathy or a meningoencephalitis. Well, the next thing is, after making a diagnosis, if you could have, is what are the conditions that requires them to be in ICU, which are comatose patients, shock, respiratory distress, status epilepticus, but the most importantly, raised ICP. And if you look at the data from adult and children together, raised ICP is present in almost 70% of patients with viral encephalitis who come to hospital. And if it is there, we know that the mortality is very high. So the first priority in these patients is to bring down the raised ICP or treat the raised ICP. And how do you treat that? I'll come to that. But if you do not have still a diagnosis, you still start these patients on a broad spectrum antibiotic, but here it is ceftriaxone, nothing else, because it will cover pneumococcus, Haemophilus, commonly seen scrub typhus, and then you could have a specific diagnosis. You may go for doxycycline, or it would still cover enteric also. So most of the infections are covered with ceftriaxone, and one would not add vancomycin in our setup to these patients, as some of the Western textbook would say, because we do not have pneumococcus resistant to ceftriaxone in that proportion. Acyclovir is administered if you suspect herpes, and I said there are two reasons. One, there are focal deficits, RBCs in CSF, or your MRI is suggestive. These days, of course, short duration therapy with drugs. I'll go to the next one, and because you may be all waiting for lunch. Dexamethasone came with the big idea that it reduces inflammation. In children, there were studies that favored it, but this is the last one which came, the large study from Malawi, which did not show any advantage of using dexamethasone in children. And Cochrane review over the studies over the years, in fact, shows very interesting trend that children in developing countries who were treated with dexamethasone do not show any advantage. In adults, the studies are only from the developed countries, which show clearly an advantage for using dexamethasone in bacterial meningitis in adults. But dexamethasone use in our setup, I would think, is limited mainly to tubercular meningitis. Data support use of corticosteroids only in high-income countries, where it marginally reduces mortality and disability. This was another study from Latin America which did not show any advantage of dexamethasone in children. And reason for this is our study which we published in 2006, and my assumption is our population is already chronically stressed with one or other infection, and their also nutritional status is poor. And if you see these two box plots, hearing sequelae and all sequelae, they were, in these patients, cortisol levels at the beginning or at the time of their arrival were already very high. In these patients, if we are giving cortisol, it's unlikely to do anything more. So tuberculosis, there is no doubt about it. There are clear evidence that it reduces death, it reduces the risk of disability, and quite significantly. Glycerol is another adjuvant therapy, and about which there was a paper a few years ago on adults from Africa. That paper again was from Malawi, and it did not find the advantage of using glycerol. But it's very inexpensive medicine, and this trial from Latin America in children at least found that it reduces severe neurological sequelae and neurological sequelae plus death. We also did a small study, but particularly to see how glycerol makes a difference. And this is the data from that study on glycerol, dexamethasone, glycerol, dexamethasone, on osmolarity of these patients. Serum osmolarity falls in first 24 hours when you are using glycerol. And that equates to reduction in CSF production by about 20%. And that could be the reason how it helps without any. So this 3% fall in osmolarity corresponds to about 20 to 30% reduction in CSF and therefore CSF pressures. I had been very particular about the fluid therapy in CNS infections, and we published first paper on the meningitis, that fluid restriction do not improve the outcome of acute meningitis. After this, it had been studied by many others, and now it is a standard practice. And the reason is very simple. The data here is, if you see patients with hyponatremia or without hyponatremia and they received fluid restriction, there is higher mortality and higher sequelae as compared to those who received maintenance fluid therapy. And it is because it would help in maintaining cerebral perfusion. This was a study which came almost 6 years after our first publication. And we did another study later supported by WHO, and you can see here those who received normal fluids had almost half the mortality than those who had restricted fluid therapy. So in patients with CNS infection, maintaining good perfusion is important. And I'll come to this when I touch the next concept of raised ICP treatment in these patients. We had been so often treating these patients with all kind of osmotic diuretics. ICPs, of course, I have shown earlier, is present in many of these patients, especially in viral encephalitis. But even in our pediatric ICU, we have almost half the patients would have raised ICP if they are admitted for suspected CNS infections. And cerebral herniation is seen in 30% of patients who die with CNS infection. So you know that this is a very important cause of death. In meningitis, what it does is to reduce event in the first 3 days, when the cerebral pressures are high, the cerebral perfusion goes down. And as the pressures come down with the treatment of the disease, the cerebral blood flow increases. So in first few days, there is decreased cerebral blood flow because of raised ICP. That's the concept that we need to remember. And therefore, we thought of a treatment approach based on some of these experimental studies, that if you try to maintain these patients' blood pressure at a higher level, you would improve the cerebral blood flow. And this is, give me 2-3 minutes more, maybe. Because what is happening here, when you increase the blood flow, the cerebral blood flow, increase the blood pressure, the cerebral blood flow goes up. Okay.
If you want this thing, na, marker, na, you can use this. So you can use pointer, and now you can move there.
Yeah.
You can see there.
Right.
Suppose you want to use here, you have to just.
Okay. So we did a study after, a preliminary on cerebral perfusion targeted therapy in children with CNS infection, and then a randomized controlled trial. And I'll show only a few aspects of that. Here, what we did was to target blood pressure to be at 90 to 95th centile, and only if they needed any other intervention. So the blood pressures were raised using an inotropic agent and tried to keep it within the higher side of normal. The other group received the usual therapy with osmotic diuretic, and we were monitoring intracranial pressure of these patients, which we would try to keep it below 20. And what I can show you here is that those patients who had received blood pressure supporting therapy, that is cerebral perfusion pressure targeted, they had much better, this is the blood pressure there, and their perfusion pressures were much higher than those who had therapy to reduce their ICP. And all of it translated into good outcome, which I would simply show here first in relation to death. The mortality was half in those patients where we targeted blood pressures on the higher side and maintained a cerebral perfusion pressure above 60. And you can see this Kaplan-Meier curve, which shows initial, it shows that, much lower survival for those with where ICP reducing therapies were targeted. Even in the long term, at 5 years, Normal survivor, 80% in those who had cerebral perfusion pressure targeted, and here only 50% where target was ICP reduction. And same is true for overall composite outcome. You can see that patients who had cerebral perfusion targeted therapy had much less worse outcome. Only 22% finally had death or severe disability compared to almost 50% of those who had ICP targeted therapy. These were the patients who otherwise had coma with GCS score below 8. And then use of osmotic diuretic. We found that mannitol in our data from the meningitis study from early 2000 had those who received mannitol had a much higher mortality, 3 times higher. And especially when we looked at their urine output and mortality, those who had high urine output had almost double the mortality. So although we may be reducing intracranial pressure, but we were losing on the life. And therefore, 2-3 years ago, we did this trial of mannitol and saline group, and now we use only hypertonic saline. What I would like to show you here is only the outcome. And this is here, the survival curves again. Those who had mannitol and those who had saline. So the survival rates are much higher, or the mortality is much lower in those who had saline group. So success was achieved early, and also